Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 3 of the Neurology chapter. We're going to start by talking about pathology, beginning with developmental disorders. Disruption during the development of the nervous system can be disastrous, leading to a variety of the conditions that we're going to discuss, beginning with neural tube defects. Failure of the neural tube to close can lead to a continuum of these defects extending from anencephaly to subtypes of spina bifida, which is discussed in more detail in Chapter 4. Hydrocephalus. This literally translates to water in the brain, caused by the excess accumulation of cerebrospinal fluid in the ventricular system of the brain from impaired CSF flow, resorption, or excessive production of various causes. Because of the enclosed space of the skull, signs of increased intracranial pressure develop, such as headache, nausea, vomiting, papilledema, sleepiness, coma, and even death caused by herniation. It is important to note that in infants, increased intracranial pressure symptoms present as irritability, poor feeding, muscle hypertonia, hyperreflexia, and a bulging of the fontanelle. Treatment often includes opening up the ventricles, a ventriculostomy, or placement of cerebral shunts. Shunts can bypass outflow obstructions or drain excessive CSF into body cavities, such as the abdominal peritoneal cavity, where it can be resorbed. Based on the underlying mechanism, hydrocephalus can be categorized into communicating and non-communicating categories. They can be further subdivided into congenital or acquired. Non-communicating, obstructive. There is CSF outflow obstruction in the ventricular system. Congenital, caused by atresia or webs within the ventricular system, for example, within the cerebral aqueduct of Sylvius, Arnold-Chiari malformation, or Dandy-Walker syndrome. Arnold-Chiari malformation. This is a malformation of the brain in which there is a downward herniation of the cerebellar tonsils through the foramen magnum. Conditions associated with this malformation include Syringomyelia and connective tissue disorders, such as Ehlers-Danlos and Marfan syndrome. Dandy-Walker syndrome. This consists of partial or complete absence of the cerebellar vermis, enlargement of the fourth ventricle, and cyst formation near the internal base of the skull. Dandy-Walker syndrome is associated with corpus callosum absence and karyotype abnormalities. Acquired types occur following subarachnoid hemorrhage, which causes obstruction within the channels of the ventricular system, for example, stenosis of the aqueduct of Sylvius. It also occurs from an underlying brain tumor, such as an ependymoma, medulloblastoma, or colloid cyst within the ventricular system, or one causing external compression of the ventricular system. Now we'll talk about communicating non-obstructive. There is impaired CSF resorption by arachnoid granulations or villi caused by scarring or fibrosis following infectious, inflammatory, or hemorrhagic events, such as post-meningitis or arachnoid bleeds. Normal pressure hydrocephalus, or NPH. This disease entity is often misdiagnosed as Parkinson's disease or Alzheimer's disease because of the chronic, insidious nature of the symptoms. Because of the chronic dilation of the ventricular system, normal pressure hydrocephalus presents classically with the triad of urinary incontinence, gait disturbance, and dementia in older adults, despite having normal CSF pressures on lumbar puncture. This constellation of symptoms is often termed wet, wobbly, and wacky for urinary incontinence, gait disturbance, and dementia. The gait disturbance is typically an early and prominent feature of NPH and can help distinguish this disease from other forms of dementia, in which gait disturbance may be a late symptom. Treatment is with a ventriculoperitoneal shunt that drains the excess CSF to the abdominal peritoneal cavity. If performed early enough, shunting can reverse the symptoms. Hydrocephalus ex vacuo. There is a compensatory enlargement of CSF because of atrophy or loss of brain parenchyma caused by various diseases, despite no increased CSF pressure, for example, post-traumatic brain injury, as well as dementias such as Alzheimer's, Pick's, and Huntington's dementia. Signs of increased intracranial pressure, such as papilledema, can also be confused with another disease process known as idiopathic intracranial hypertension, formerly known as pseudotumor cerebri. Idiopathic intracranial hypertension is seen in young, obese females who present with headache, nausea, and vomiting. They may also complain of pulsatile tinnitus, described as a whooshing or buzzing, as well as diplopia from cranial nerve 6 palsy, and deteriorating vision, eventually leading to blindness if not treated. The mechanism of this disease process is poorly understood, with speculation that it is caused by increased CSF production or decreased venous drainage from the brain. On fundoscopy, these patients have papilledema. CT scans will reveal no mass, but sometimes small, slit-like ventricles and an empty cella sign can be seen. Diagnosis is usually made by measuring the opening lumbar puncture pressure, which is greatly elevated. Treatment of this condition starts with drainage of excess CSF by lumbar puncture. Serial lumbar punctures may be necessary. Acetazolamide also decreases CSF production. Patients should also discontinue medications that increase intracranial pressure, such as high-dose vitamin A derivatives, tetracycline, hormonal contraceptives, and danazol. Surgery is a last resort in which a CSF shunt and optic nerve decompression via fenestration can be performed. Syringomyelia, also known as a syrinx. It's a cystic cavity that forms within the spinal cord, which expands over time, leading to pain, weakness, and paralysis. Upper extremities are usually affected because of a mass effect on the spinothalamic tracts. The dorsal column is usually spared. Pressure, vibration, touch, and proprioception remain intact. Typically, this disease presents as a cape-like loss of pain and temperature sensation in the back and arms. A syrinx can be congenital or associated with Arnold-Chiari malformation. It can also be acquired as a complication of trauma, meningitis, or tumor. Neurocutaneous syndromes, also known as phacomatoses. These syndromes present with lesions on the skin or eye. Neurofibromatosis. Neurofibromatosis type 1 is an autosomal dominant mutation of NF1 on chromosome 17, which is a tumor suppressor that inhibits P21 RAS oncoprotein. This mutation leads to uncontrolled cell proliferation. Characteristics include subcutaneous neurofibromas, groin and axillary freckling, cafe au lait spots, which are light brown macules, Lisch nodules, which are iris hamartomas, optic nerve gliomas, and epilepsy. Neurofibromatosis type 2, or central neurofibromatosis. This is an autosomal dominant mutation of Merlin on chromosome 22, which is also a tumor suppressor gene. This leads to bilateral vestibular schwannomas, formerly known as acoustic neuromas, that can cause sensorineural hearing loss. Schwannomas of other cranial nerves, meningiomas, and ependymomas may also be seen. Think NF2-22-2. Neurofibromatosis type 2 is chromosome 22 and can cause 2 or bilateral acoustic neuromas. Tuberous sclerosis. This is an autosomal dominant mutation of Hamerton or tuberin, which are tumor suppressors, leading to a multisystem disease that has a variable penetrance. Signs include facial angiofibromas, hypomelanic macules or ash leaf spots, shagreen patches, a raised or textured skin lesion, cortical tubers, cardiac rhabdomyomas, and renal angiomyolipomas. Sturge-Weber syndrome, occurring sporadically because of embryonal development anomalies. This syndrome presents with seizures at birth and is associated with port wine stain of the face. Early onset glaucoma, mental retardation, and ipsilateral leptomeningioma, which increases contralateral seizure or epilepsy likelihood. Von Hippel-Lindau disease. This is an autosomal dominant mutation of VHL tumor suppressor gene on chromosome 3 that leads to hemangioblastomas in the retina, kidney, spine, brainstem, or cerebellum, as well as angiomatosis in various organs, often associated with renal angioma, renal cell carcinoma, pancreatic cysts, cyst adenomas, and pheochromocytoma. Brain lesions. Understanding anatomy and relating it to the respective function is key in localizing neurologic lesions. Table 13-2, which you can see in the book, is a list of common pathologic examples that can be encountered. Let's start with aphasia. Aphasia is an impairment of language ability that ranges from not remembering words to being completely unable to speak, read, or write, depending on the area and extent of the dominant side of the brain affected. It usually follows a stroke, but can develop from conditions such as infection, tumor, or brain injury. In contrast, dysarthria is the motor inability to speak. Vascular dysfunction. Similar to a myocardial infarction, a stroke is caused by impeded blood flow, leading to specific neurologic defects, depending on the area of the brain affected. Just as time is muscle in a myocardial infarction, time is brain in a stroke. Irreversible damage develops within a few minutes, so reperfusion with therapies such as tissue plasminogen activator, or TPA, quickly is important. Strokes can be classified by their etiology, either ischemic or hemorrhagic. 85% of strokes are ischemic because of embolic phenomenon from atherosclerotic lesions of atrial fibrillation. Carotid dissection, endocarditis, or a patent foramen ovale, allowing a blood clot in the leg that travels from the right atrium to the left atrium and then to the left ventricle and brain, also cause ischemic strokes. Approximately 15% of strokes are hemorrhagic, in which intracerebral bleeding results directly from vessel rupture or hemorrhagic conversion from an ischemic stroke because of increased vessel fragility. A CT scan is used to differentiate between ischemic and hemorrhagic strokes initially, followed by magnetic resonance imaging. Prior to a stroke, a patient may have experienced a transient ischemic attack, in which they experience brief neurologic dysfunction that lasts less than 24 hours without acute infarction. For example, some patients experience amaurosis fugax, which is a painless transient loss of vision caused by atherosclerotic embolization, usually of the carotid body, to the retinal arteries, while others may have aphasia, slurred speech, or confusion. TIAs are usually a harbinger of an impending stroke and usually warrant a workup as an outpatient or inpatient, depending on various factors. Stroke. The anterior cerebral artery supplies the anteromedial hemispheric surface, where leg, foot, motor, and sensory areas are affected. The middle cerebral artery supplies the lateral hemispheric surface, where face, arm, motor, and sensory areas are affected. In addition, patients may show aphasias if the dominant lobe is involved, usually the left. The posterior cerebral artery supplies posterior and inferior hemispheric surfaces, where homonymous hemianopsia with macular sparing can occur. Aneurysm. An aneurysm is a balloon-like bulge of a blood vessel that involves all three layers of an artery, the intima, media, and adventitia. An aneurysm may rupture, causing subarachnoid hemorrhage. Saccular or Berry aneurysm occurs at bifurcations in the circle of Willis, where rupture leads to hemorrhagic strokes or subarachnoid hemorrhage, often associated with Marfan syndrome, Ehlers-Danlos syndrome, and adult polycystic kidney disease. Anterior communicating artery is the most common location of an aneurysm, where lesions lead to bitemporal hemianopsia. The posterior communicating artery is a common site of aneurysm, which can lead to cranial nerve 3 palsy, where the eyes are down and out. Charcot-Bouchard microaneurysm. Chronic hypertension leads to rupture of small vessels, usually within the basal ganglia, pons, and thalamus, which is not typically seen on angiograms. Venous. Dural sinus thrombosis. It's a rare stroke that results from the thrombosis of the dural venous sinus, resulting in stroke-like symptoms, headaches, weakness, and seizures. A CT scan shows an empty delta sign, gadolinium enhancement of the sinus wall and periphery of the clot, but not within the clot itself. Brainstem. Unlike cerebrum strokes, brainstem strokes often involve cranial nerves. Most notably, brainstem strokes show alternating signs. Cranial nerve involvement and hemiparesis are on opposite sides. Trauma. Traumatic brain injury is a major cause of death and disability worldwide, especially for young adults. In traumatic brain injury, or any situation of altered mental status, a patient's level of consciousness is graded based on the Glasgow Coma Scale. The scale ranges from 3 to 15 and classifies brain injuries as mild, 13 to 15, moderate, 9 to 12, or severe, 3 to 8. Endotracheal intubation is generally recommended in severe head injury with a Glasgow Coma Scale of 8 or less. Classification. Diffuse. Diffuse axonal injury is a devastating type of traumatic brain injury due to shearing forces from a sudden acceleration or deceleration of the head. Diagnosis is usually made via MRI because it is difficult to detect on a CT scan. Patients generally end up staying in a coma and never regaining consciousness. Focal. Epidural hematoma. As a result of temporal bone fracture from trauma at the pterion, the weakest part of the skull, the middle meningeal artery can rupture, leading to a buildup of the blood between the dura mater and the skull. Patients generally have a lucid interval but soon rapidly deteriorate because of transtentorial herniation, which will be discussed later, as a result of expansion of the hematoma under systemic arterial pressure. CT scan generally shows a biconvex lens that does not cross suture lines, but can cross the falx and tentorium. Subdural hematoma. Bleeding between the dura and arachnoid membrane from the rupture of small bridging veins as a result of rapid changes in velocity, acceleration or deceleration in whiplash or shaking. It is commonly seen in older adults and alcoholics because of brain atrophy, which increases the dural space and results in a wider distance in which the veins have to travel, making them vulnerable to tear. The same principle applies to children from shaken baby syndrome, who tend to have larger subdural spaces because of their smaller brains. Unlike an epidural hematoma, subdural bleeds are slow venous bleeds with delayed onset of symptoms. As intracranial pressure gradually increases, patients begin to have increasing headache and confusion. CT generally shows blood collecting in a crescent-shaped pattern that crosses suture lines but cannot cross the dural reflections. Subarachnoid hemorrhage. Bleeding between the arachnoid membrane and pia mater surrounding the brain results from rupture of a cerebral aneurysm, especially Barry aneurysms in Marfan syndrome, Ehlers-Danlos syndrome, and polycystic kidney disease, or from arteriovenous malformation, spontaneously, or from trauma. Patients generally complain of sudden onset of the worst headache of their lives, or may present beforehand with warning leaks as general headaches. Most subarachnoid hemorrhages are detected on CT after the onset of bleeding, which shows blood in the cisterns and filling of blood along the sulci and fissures. If a CT scan is negative, a lumbar puncture is performed and CSF is collected, which may show elevated blood cells equally in all tubes collected, or the CSF may appear yellow because of the bilirubin from breakdown of heme from red blood cells. Treatment consists of preventing rebleeding by clipping or coiling the aneurysms, as well as treatment of seizures, vasospasm, and hydrocephalus. Vasospasm is treated with the calcium channel blocker nimodipine. Intracerebral hemorrhage. This is bleeding within the brain tissue itself that can occur as a result of trauma, such as from skull fracture or from AVM, or can result from stroke, bleeding within a tumor, or amyloid angiopathy. Intracranial hemorrhage risk factors include hypertension, diabetes, menopause, cigarette smoking, and alcoholism. Basilar skull fracture. Traumatic fracture involving the base of the skull, leading to damage to the meninges. As a result, there can be CSF rhinorrhea or otorrhea and ecchymosis of the mastoid process of the temporal bone, which is called battle sign, or periorbital ecchymosis, which is called raccoon eyes. Cerebral contusion. This is literally a bruise to the brain caused by multiple microhemorrhages from small blood vessel leaks. An example is coup injury, in which the coup injury occurs at the site of impact, and the contre-coup injury occurs on the side opposite the impact, where the brain recoils against the skull. That's the end of this section. In the next section, we will begin with herniation.